So hello, my name's Ed.
My name's Johnny.
And we're going to be doing a quick run-through of some of the surgical esophageal disorders that us budding medics need to know about to get through surgical finals. Pretty excited about that, Johnny?
I'm very excited.
Very excited.
Sweating.
Good to have you, actually.
Yes, thank you very much for inviting me on.
Yeah, good to have you here.
Yeah.
Brought you mainly for the comedy. You know,
I'm a bit of a comic genius.
Comic genius. Inject some of the Stephen Merchant into my Ricky Gervais. Or maybe it's the other way around.
Well, you're the taller one. Maybe you should be Merchant. I'm the fat one. Gervais.
There we go. Done. So during this relatively brief discussion, let's try and keep it relatively brief, because surgery is not really my cup of tea. We're going to talk a little bit about the bits of anatomy that we need to know to understand the esophagus, important bits and bobs there. We're then going to talk about one of the most common presentations we need to understand, that's dysphagia, and how to break down the causes. We're then going to have a look at the most important conditions of the esophagus, and here we're going to look at some of the tumours, whether they be benign or malignant. We're going to have a look at gastroesophageal reflux disease, classification of hiatus hernias, and then finally talk about some of the treatments. Finally, we're going to look at something quite rare, that's esophageal rupture. So let's start by talking a little bit about the surgical anatomy of the esophagus. And I'm going to hand over to you here, because you are the esophageal anatomy expert.
I am.
On the podcast.
Thank you very much.
Go for it. Yeah.
Okay, well, the esophagus is a hollow tube running from the mouth to the stomach.
Yep.
It's 40 centimetres from the mouth to the stomach.
Mm-hmm.
It starts at the spinal level of C6,
Yep.
at the cricoid cartilage.
Cricoid cartilage.
Yeah.
Yep.
And it goes behind the thyroid and the trachea.
Mm-hmm.
And then other anterior parts are the left bronchus,
Mm-hmm.
the aortic arch,
Yep.
and the left atrium,
Left
which is
atrium.
important later.
When we talk about those causes.
And then it goes through the diaphragm
Yep.
at T8.
Which bit of the diaphragm is that?
That's the left side.
What about the muscle layers in the esophagus?
Well, it starts as a striated in the upper third.
Yep.
The middle third is a mixture of the
Yep.
striated and the smooth muscle, and then
Yep.
the final lower third is just smooth muscle. It's composed of, the epithelium is squamous non-keratinizing.
Squamous, non-keratinizing. That's important, isn't it? Because when we talk later about pathological processes such as
There's a
regurgitation
change.
from the stomach, Barrett's esophagus, things like that. So it's important to know that the normal lining of the esophagus is indeed squamous. Okay, I think that's pretty much
That's a fair amount of anatomy.
fair amount of anatomy.
For,
Enough
for
anatomy
what we need to know.
for
yeah.
us. Okay. So basically, I'm going to talk a little bit now.
Go.
Feel free to-
I'll
feel
chip
free-
in. I'll chip
feel
in
free
in case I feel you're not giving
interrupt
the
at any
necessary
time.
knowledge.
Okay. There are three important basic swallowing symptoms that we need to be aware of. These are dysphagia.
And what's that?
That's actually a conscious difficulty in swallowing. It's the most common one. There's aphagia, which obviously is a complete inability to swallow, and odynophagia, which represents painful swallowing. Now, in this part of the podcast, what we thought we'd do is go through the kind of basic causes of dysphagia and split them up.
Let's do it.
Let's do it. The best way to split them up, I think, is into oral causes, neurological causes, and mechanical disorders. And there are a number of kind of sub-classifications there which enable you to quickly figure out what the cause is. And this is particularly useful, say, in a Viva situation or in an OSCE situation. So we'll first talk a little bit about oral causes. I like to divide oral causes up into painful oral causes and obstructive oral causes. However, it's important to realise that there often is some overlap between this, and some causes that are painful can also be obstructive, etc., etc. When we think about painful oral causes, we're thinking about things such as tonsillitis, pharyngitis, aphthous ulcers in the mouth, and fungal infections, for example, such as candidiasis. When we think about obstructive things, say pharyngeal pouches, retropharyngeal abscesses, and of course, epiglottitis.
And obviously the overlapping quinsy, both painful and obstructive.
There we go. That's why we got you on, Johnny.
I know.
With little comments like that. So, now moving on to neurological disease.
How would you split this up?
I'd split this up probably into bulbar and pseudobulbar. Now, what's the difference between bulbar and pseudobulbar? It's not an easy question, and this isn't a neurology podcast, but being medically minded, we like to think about these things. So bulbar process basically means involving predominantly lower motor neuron. So you'll be looking for lower motor neuron features such as
circulation, wasting.
Yep, absolutely. Absence of a brisk jaw jerk would be another one. Okay, and pseudobulbar is really an upper motor neuron thing. So there you're going to see a spastic tongue.
Maybe small as well.
Maybe small tongue. And also
no fasciculation. And an increased jaw jerk. Now, the important diseases that go with each of these, in bulbar, obviously you're thinking about things such as motor neuron disease, syringobulbar, and any of the Guillain-Barré syndromes. In pseudobulbar, representing the upper motor neuron process, we're thinking about CVAs, multiple sclerosis, and MND. And that's the point that we really made previously, Johnny. It's a very mixed picture in MND.
With motor neuron disease, there are a number of subtypes, obviously, but one of the important things clinically to be aware of is that often there is a mixed pattern of both upper motor neuron and lower motor neuron signs.
That's great.
Okay? And finally, in neurological disease, there are a number of localized conditions that can also cause it, such as Crest syndrome, it's part of scleroderma, and achalasia. But we're going to talk a little bit about that later.
In a second, I believe.
Okay. So, Johnny, the final section, mechanical causes.
Well, obviously, the best way to think about mechanical causes is dividing it up into things in the lumen, things in the wall, and things outside.
Okay. Let's start in the lumen.
I want to start, and basically, it's any obstruction of the lumen. So it could be a foreign body, or it could be a food bolus. In the wall, obviously, carcinoma of the esophagus, chronic esophagitis, and trauma from maybe iatrogenic things such as endoscopy.
Stuff like that. We're going to talk a bit about that later. And then lastly, and I actually think most complex, is to think about the things outside the wall. But there is a way to understand that better. How is that?
I like to think about it anatomically. So start from where the esophagus starts, at the top. So maybe a thyroid goiter. Lower down, obviously, there's enlarged lymph nodes in lymphoma or something like that. Could be a bronchial carcinoma. Could be an aortic aneurysm putting pressure on it. Or in mitral stenosis, you get enlargement of the left atrium.
Okay. So it's important, really, for these causes to think about the anterior relations of the esophagus, things that could be pressing on it. Okay. So that pretty much completes what we're talking about dysphagia. In summary, you can divide dysphagia up into oral causes, which may be either painful or obstructive. You can divide it up into neurological causes, which may be pseudobulbar or bulbar.
Or local.
Or you can divide it up into mechanical causes, in which case it can be within the lumen, in the wall, or outside. And when thinking about outside, think about the anatomical relations of the esophagus. Okay, so that really completes what we're going to say about the important symptom, or the most important symptom of esophageal disease. What we're going to go and do now...
Could I do a sideline quickly on Achalasia?
Okay.
Or, well,
I like that.
I don't know where you want to put it.
No, I think achalasia would be good, actually.
What is it? What question?
Well, you were going to talk about it, but if you want me to tell you about it, that's fine. It basically represents a degenerative process of Auerbach's plexi, which are lots of tiny nerves that surround the esophagus. This leads to loss of peristalsis, usually in the lower third.
Loss of relaxation.
So loss of relaxation, peristalsis in the lower third. Particular associations with achalasia are squamous cell carcinomas, and we're going to go on to talk about that in a minute. So let's not get bogged down in that here. There are a number of treatments that are important. There are 3 important treatments that we thought we'd try and remember. What are they?
The endoscopic dilatation. Or Heller's cardiomyotomy.
Another wonderful eponymous procedure.
Which obviously can be open or endoscopic.
Like with all of these things.
And botulinum toxin injection.
That's quite interesting.
That's a new treatment.
New technique.
Getting good results at the moment. Look it up.
Look it up, kids. Look it up. Okay. The other thing, actually, we didn't mention as a cause of wall-based dysphagia was the Plummer-Vinson Syndrome.
Oh.
Another eponymous syndrome to add to the list. What's that about?
It's a web-like blockage of the esophagus associated with chronic iron deficiency anemia.
So it's another one of those bizarre syndromes associated
Not
with
essential,
iron.
but distinction.
But it's distinction. It's kind of along with those, angular stomatitis, glossitis, all of those bizarre anemia causes. Okay. So let's go on now to talk about tumours of the esophagus. Now, we think, as with most tumours, there's quite an easy way to divide these.
With everything.
As with everything. So how would you divide them?
I'd go primary and secondary, firstly. So obviously the primary can then be divided into benign and malignant.
Yeah.
Benign, often rare. We don't have a lot of information on them, but they can affect any part of the esophagus. So they can be ones extending into the lumen, so polyps.
Yeah.
They can be the vasculature, so hemangiomas.
Mm-hmm.
They can be the fat, lipomas, or the muscle, leiomyomas.
Okay, so there are a few bizarre ones there, but the best way to think about that is just to think about the different bits of the esophagus and then add an oma really on the end of the structure.
Always add the oma.
Add the oma, that's what I like to do. Okay, malignant tumours. Let's talk about them. Let's talk a little bit about the epidemiology. Epidemiology is always quite boring, but there's specific features in epidemiology which are quite important here, I think.
The way I think about this, just really quick, if you're thinking of something.
Yeah.
Iranian male smokers.
I've got a good picture in my mind.
I hope everyone does.
It's more common in men. It's more common in Iranians, but also in other people, Chinese
and certain areas of Africa.
And in
older people.
And in older people. So those are the kind of key features. What about risk factors? We've already spoken about one. Smoking. But I like to divide up risk factors. Let's talk about how we can divide up the risk factors.
Best way, with everything, think lifestyle and other diseases.
Lifestyle and other diseases. Okay, so lifestyle factors. Smoking.
Big one. Stop smoking.
Stop it.
Alcohol. I know you enjoy it. Once again, cut down.
Cut down, not stop. Cut down, because cardioprotective, red wine, etc. Okay.
And diet.
Diet.
What kind of things?
Sideline. Well, salted fish, actually, is particularly associated with esophageal carcinoma, as is pickled vegetables.
Pickled vegetables.
Which is, I don't know if they eat a lot of pickled vegetables in Iran. I would have thought Japan would be
That would be...
But anyway,
I would have thought.
Salted fish, pickled vegetables. And what about diseases? What diseases?
Well, we've mentioned a number of them.
Yep.
So chronic esophagitis.
Yep.
Causing Barrett's esophagus, and we'll get on to what type of tumour that causes. Corrosive strictures, once again, from esophagitis.
Yep.
Plummer-Vinson Syndrome.
Yep.
And Achalasia.
Which, as we mentioned, was the degeneration of Auerbach's plexus and is associated with squamous cell carcinoma. So, let's talk about the two specific types now of esophageal carcinoma. What types do we have?
50% are squamous cell.
Yep.
50% adeno.
Okay. We've already mentioned some of the associations with squamous cell, the Plummer-Vinson syndrome, for example, and Achalasia. But tell me a little bit about associations of adenocarcinoma.
Well, Barrett's esophagus from gastroesophageal...
Take your time.
Gastroesophageal reflux disease.
Okay. Which, as we're going to go on to talk about that later. But basically what happens is, as we said, the esophagus is lined with the squamous cell lining, and the reflux of acid up from the stomach causes this to become irritated, inflamed, and part of the body's response is to go through metaplasia, the changing of one cell type to another, into columnar, and this represents Barrett's esophagus, which has a higher potential to turn into adenocarcinoma.
Indeed.
Okay, so that's all very pathological and a bit boring. Let's go on to talk about the clinical features. Once again, you've got a good way of dividing this up.
As always, general and specific causes. So, general features of malignancy, so weight loss, anorexia, malaise, possibly an anemia.
An anemia, okay, yeah, good.
And specific ones.
What's the major specific one?
Dysphagia.
Dysphagia, as we've already said. What would you suspect in the history that would make you think about malignancy?
If you think about it, it's a slow-growing tumour.
Yeah.
So it's going to be a progressive dysphagia, starting with solids and then moving to more liquid substances.
Okay. Any other features on the specific?
Yeah, there may be some bleeding.
Causing a hematemesis or something like that.
Indeed.
Yeah.
And a hoarse voice because it's affecting the recurrent laryngeal nerve.
Yeah. Specifically the left laryngeal nerve.
Why is that?
Because,
Why is
well, the left, I mean, I'm not a great anatomist and never have been, but I think the left recurrent laryngeal nerve, it arches round the aortic arch and comes up and runs in between the groove between the trachea and the esophagus, where obviously if there's a tumour, there could be pressure on it, and that will lead to
That's the way I understand
damage
it.
to the thing, which leads to hoarseness.
And obviously, if you have dysphagia, then there's risk of aspiration pneumonia.
Exactly. Right. So now I'm going to talk a little bit about some of the investigations that one can do. Now, if you listen to the Differential Diagnosis podcast, I spoke a little bit about...
I love that one. I thought that was some of your best work.
Really?
Yeah.
Well, maybe you'd like to do some slides for it or something.
Oh, that'd be great.
That would be great.
I've got nothing better to do.
No, I mean, finals is not that long away. It's
I'm not
fine.
worried.
No. Anyway, please don't interrupt me again.
Sorry.
I was just getting into the flow. Anyway,
Yeah, sorry.
with investigations, you can divide them up into kind of 5 things. And I like to, when you're on your ward round at 8 a.m. on a Monday morning, someone says, what are the investigations for this? I like to go through a few things in my head. I go through sets of things. So I think about cultures. Could we do any cultures? I then think about bloods. Could we do any bloods? And if so, would they be arterial or venous? I then think about imaging. In this case, we want to do a chest X-ray, CT scan, MRI, ultrasound, etc., etc. I then think about scopic investigations, and by that I mean, do we want to do an endoscopy? Do we want to do a colonoscopy? And I include biopsies in that, so FNA biopsies, things like that. And then finally, I think about functional things, and depending on the organ system, that could be an ECG, it could be lung function tests, it could be pH manometry, particularly in this case. That's it. That's what I think about in investigations. So when we're thinking now about investigations in esophageal carcinoma, or if we suspect esophageal carcinoma, let's go through some of those and think about it. So, cultures.
I wouldn't say they're necessary in this.
No, I mean, no need to
situation.
do sputum, CSF,
Yeah.
not really useful. Bloods, arterial bloods,
No, not in this
not
case.
useful. Okay. Venous bloods.
Yes, normally helpful.
Yep.
So obviously looking for any signs of anemia.
Okay, so the FBC, which anemia possibly.
LFTs, maybe deranged if you've got metastases to the liver.
Metastases to the liver, absolutely.
Usenes, possibly some problem with nutrition or
Dehydration, or
hydration
signs of being unwell, all that kind of stuff. Maybe calcium for bony mets secondary to that. Okay, so those can be quite useful. The venous bloods can be quite useful. Moving on to imaging now. If you could have one imaging test for this, what would you choose?
I'd go for a barium swallow.
Okay.
And if it was an esophageal carcinoma, I'd probably show some apple core shaped
So
lesion.
apple core, that is the typical effect. Remember that for EMQs, remember that for all that stuff. It's apple core appearance on barium swallow. If I could give you another imaging test, actually, no, I'll give you 2 more imaging tests.
Chest X-ray.
Chest X-ray, always good.
Standard. And staging. You need staging. So CT.
So CT scan. Okay, we're not going to get into detailed staging here because I think, that's really pretty irrelevant unless you're doing the MRCS. Scopic investigations.
Endoscopy with biopsy.
That's got to be your definitive diagnosis. Lastly, functional. I don't think there are any real important functional scans there. I mean, there are some when we're going to talk about gastroesophageal reflux disease, but in terms of esophageal carcinoma, not really important. Okay, so we've procrastinated enough about that. Let's talk a little bit now about management. Now, once again, there's an approach that you can use in management that's quite useful, I think.
Well, obviously, you've got to do it as an MDT.
Always say those words MDT. Guaranteed
Essential.
brownie points. But don't say them too cynically, because then people will think you're a bit of a tit.
Which we're not.
Which is the reason we're recording this podcast. To prove that we're not. Anyway, so, MDT.
That and to get girls.
Well, yeah.
It's
Johnny at podmedics.co.uk.
Okay, anyway, so, yes, you'd involve palliative care team and Macmillan nurses and a number of other people.
So oncologists. So
maybe SALT, speech
SALT.
and language, because
could be appropriate in this situation. We should do that. So, otherwise, MDT, you said the magic words. But how else can you divide these things up?
So, conservative, in this case it's generally palliative
Yeah.
care. And I like to classify this as those affecting the size of the carcinoma and obstruction.
Yep.
And obviously analgesia. So size, you can have alcohol injections.
Yep.
You can do laser coagulation.
Laser it.
And palliative radiotherapy. And then the size, the obstruction, you can stent it or you can dilate the tumour.
Yeah. But these are all, as I said, these are all palliative things, aren't they? Yeah.
Medical, obviously, you can shrink it down before treatment using chemoradiotherapy.
Yeah.
And then there's the surgical.
Okay. Basically, in surgery, there are a number of different operations you can do. They all have eponymous things like either Lewis, transhiatal, McEwen. But basically, what you're doing an esophagectomy and lymph node removal. And there are two approaches to this esophagectomy, either through the thorax, the abdomen, or both. So that's kind of the essence of the surgery. So that really completes stuff about the esophagus. Prognostically, it's not good, is it, Johnny?
It's poor. 5%, 5 years survival. So.
Okay. And even after resection, that only rises slightly to about 15%. Okay, so now, second half of this podcast, we're going to talk a little bit about gastroesophageal, that's your phone, never mind. We're going to talk a little bit about gastroesophageal reflux disease, hiatus hernias, and its treatment. So basically, Johnny, what is gastroesophageal reflux disease?
That is when the contents of the stomach, the acidic contents, are refluxed through an incompetent lower esophageal sphincter into the lower esophagus. Well, all of the esophagus, but generally affecting the lower.
And what's the problem with that?
You get esophagitis and possibly Barrett's esophagus. And also, obviously, it's painful.
It's painful. It's not nice.
No. I've had it once.
Really?
I've had lots of things.
Okay. Leave that for another podcast, maybe. Risk factors. What are the risk factors for GORD?
Once again, lifestyle.
Yep.
Alcohol. Smoking.
The same as before.
Being greedy. Large meals.
What else can cause that?
Increased intra-abdominal pressure. So if you're obese or pregnant.
Yep.
And also structural. So
structural things.
With a hiatus hernia or systemic sclerosis affecting the sphincter.
Okay. So we're going to talk about hiatus hernias in a bit. But in terms of the clinical history, patients with gastroesophageal reflux disease will present typically with retrosternal, burning chest pain that has particular associations. It's associated
What are they?
With postural effects, such as lying down, the pain will get worse. This is an obvious gravitational effect. And also it can be worse after meals, because if the stomach is distended, further distension of the sphincter makes the whole problem worse as acid goes up, etc.
Leave out the big curries.
Leave out the big curries. We're going to get to treatment later. Let's not get ahead of ourselves. Treatment's coming later. So, as Johnny's already said, if it just irritates a little bit of the esophagus, a little bit of regurgitation, you get that picture. However, in very, very severe gastroesophageal reflux disease, there can be full-on regurgitation and aspiration as a complication as well. So that's something just to bear in mind. So, investigations, Johnny. What do you think?
Well, obviously, many of you will have had it, and so isolated symptoms, it's not necessary to investigate.
No.
That's the first point.
Yeah.
And then, once again, we'd go with Ed's structure for investigations.
Yeah, we don't need to go through it now in
miss
detail.
Out a lot of them.
You know,
endoscopy
is important. Yeah.
Barium swallow, once again.
Yep.
And you can do functional ones, such as esophageal manometry and pH testing, but only if the endoscopy is normal.
Yeah, so those functional tests that we spoke about, the 24-hour esophageal manometry, pH testing, those are, as you said, only for when the endoscopy is normal.
On a side note, an ECG is probably advisable.
Anyone with chest pain, got to do an ECG. Good link. Okay. So, hiatus hernias. I hate hernias. I find it very difficult. You know, whenever I see hernias on the ward, whenever I see hernias, you know, specifically around the umbilicus, I just fall to pieces. So this is a hiatus hernia, which is a kind of internal hernia. What is a hernia, Johnny?
A hernia, now let me get this right, is an abnormal protrusion of a viscera with its coverings into an abnormal space.
Through a defect.
Yes, okay.
So it's the protrusion of a viscera and its coverings through a defect into a place where it shouldn't be.
In this case,
In this case, in the case of a hiatus hernia, it's the protrusion of the gastroesophageal junction plus or minus part of the stomach through a defect in the diaphragm into the place it shouldn't be, which is the thorax. And as we've already said, the hiatus hernia is associated with reflux esophagitis and gastritis, etc., etc., etc.
Yeah.
But there are 3 types, Johnny. Well, there's really 2 types, and there's a mix, but tell us about that.
well, most common, most important, sliding, 80%.
Yeah.
And then there's also the paraesophageal, or
Yeah.
the rolling, which is 5%. And then there's the mixed type.
Okay, but we're going to put some slides up showing those, so don't worry about that.
Okay, so
And they're mixed.
anyway,
Blood test. Best test, not blood test. Johnny, what would be the best test? This is a good one for EMQs. If I allowed you one test to diagnose a hiatus hernia, what would it be?
it'd be the barium swallow.
Yeah. Treatment of GORD in general. Okay, let's talk about treatments.
Right, conservative.
Yep.
Lifestyle, stop smoking, decrease drinking, or stop. Lose some weight,
Yep.
and eat smaller meals.
Okay.
Postural,
Yep.
put some more pillows behind your head. Yeah.
Raise the bed head.
And decrease intra-abdominal pressure,
Yep.
so lose clothes, lose weight.
Loose clothes, lose weight.
Loose clothes, lose weight.
Loose clothes, lose weight. I thought you said lose the clothes.
I might have the first time.
You might have said that was a bit of a slip. Anyway,
I can't read.
get rid of the weight.
Shed
You
it.
don't need it. But however, listen to the news, it's all genetic. People don't get fat because they eat too much. It's
No,
just because it's in their genes.
It's not their fault. It's not their
It's
fault.
not their
No, it's a big problem.
It's a big problem.
Childhood obesity.
Childhood obesity, but let's not get sidelined. That's endo.
If you see a fat kid eating chips, take them off him.
Gastroesophageal reflux disease, conservative treatment, lifestyle stuff, decrease the abdominal pressure, lose the weight, postural stuff. Great. Medical management.
I'll leave that up to you.
Medical management, basic stuff first. So you can use antacids, such as Reni, Gaviscon. These can be effective, and a lot of patients simply don't come to their doctors, they buy them over the counter and they use them. In terms of specific therapy to decrease the acidity in the stomach and therefore decrease the effects that reflux into the esophagus will have, you've got 2 options. You can use a proton pump inhibitor, and this is usually used first, or you can use an H2 antagonists. Good examples of proton pump inhibitors would be omeprazole or lansoprazole. Omeprazole you could give at a dose of 20 milligrams, lansoprazole you could give at a dose of 30 milligrams. H2 antagonists include ranitidine and cimetidine, and these are taken at night. Ranitidine 300 milligrams, cimetidine 800 milligrams. So that's the basic medical stuff. Surgery, the dreaded surgery. What are the surgical options?
Well, important fact is that the paraesophageal hernia often requires surgery, or normally requires surgery, because there's an increased chance of herniation going strangulated.
Okay, but generally those are quite rare. As we said, between 5 and 20% of hiatus hernias will be of that type.
So the normal procedure is the Nissen fundoplication.
What does that involve?
That involves taking the cardia and a bit of the fundus of the stomach and wrapping it around to create a new lower esophageal sphincter.
That's more competent, don't get the regurgitation, don't get the complications. Okay, that's great. So that pretty much completes esophageal reflux disease. In summary, the risk factors can be divided up into lifestyle, increased intra-abdominal pressure, structural things such as the hiatus hernia. Remember your definitions of hernias. Remember the definition of hiatus hernia. Remember that there are 3 types, the sliding, the paraesophageal, and mixed. Paraesophageal will definitely require surgery. However, sliding can be managed conservatively with medical things. We all spoke about that. And finally, with the procedure called the Nissen fundoplication. So finally, we're nearly there.
Yes, last topic.
Last topic.
Be quick.
Esophageal rupture.
Rare.
It is rare. Do you know about the history of this?
I like the story you tell, so if you want to, just briefly, because people have got other things to do.
People have got other things to do, and they probably got fed up with us. 1724. At the time, there was a big fat Dutch general, and one of the great fashions of the time was to eat too much and then purge yourself. Don't know why, but that's
Fashion now as well.
like to purge himself. And he used to do this regularly. And his physician, a guy called Dr. Boerhaave, was called one rainy evening because the dear general had eaten a large meal, purged himself, suddenly got awful chest pain, and 24 hours later he died. They did an autopsy, and they found that he had ruptured his esophagus. All very nasty. But basically this highlights that Boerhaave, his physician, is the guy who named Plummer-Vinson Syndrome, which is the association of violent emesis with esophageal rupture. However, esophageal rupture may be caused by two sets of things. It may be caused by trauma, either externally with a knife wound, or internally, iatrogenic, say, endoscopy. The other set of causes are what Johnny and I decided to call ins and outs. So ins is, say, corrosives, if you're drinking corrosives, bleach, and outs. So as we said, Boerhaave syndrome, as in violent emesis. So that's a bit of an aside. It's not really an important topic, but something perhaps to know about if you're asked.
Yeah.
So you happy with that, Johnny?
I'm very, very happy.
That completes the
I think it's everything you need to know. I've learnt a lot.
I've learnt a lot.
I've had fun as well.
I've had fun as well. And thanks for listening. And we'll see you next time.
Bye from Ed.
Bye from Johnny.
Thanks for listening to this podcast. For others like it and additional supporting materials, please visit our site at podmedics.co.uk.